Hi, I'm Dylan Crail, and I'm a student at CBD College, and I'm going to be presenting my patient case who suffered from a cerebral vascular accident and had since entered physical therapy in my outpatient setting. First, I will be discussing the etiology of cerebral vascular accidents, also known as strokes. So, the known cause of cerebral vascular accidents, which I'll address as CVAs from here on out, also known as strokes, depends on the kind of stroke. So you have ischemic strokes, and this can be due to a blood clot or a buildup of plaque or a fatty deposit made of cholesterol, causing lack of blood flow to the brain. Or you have hemorrhagic strokes, which this can be due to a pressure building up in the brain, causing that blood vessel to burst, also creating lack of blood flow to the brain and further damage from pooling of blood. In both cases, this causes lack of blood supply to the brain, therefore lack of oxygen, anoxia, causing tissue death within the brain. As of 2023, about 795,000 people experience a stroke yearly, and of those 795,000, 610,000 of those are first-time CVAs, and this info is based off the World Health Organization. As far as patient population, age is a considerable factor. The average age range of strokes fall between about 60, 70 years old, and the incidence increasing considerably after the age of 65. And the majority of stroke patients are actually 70 years or older. And socioeconomic status is also a big factor, as lower income people with not as optimal diets and lesser access to healthcare are also prone to strokes as well. Before breaking down the actual risk factors, I just wanted to differentiate the controllable risk factors, which are known as modifiable, versus the uncontrollable risk factors, which are known as unmodifiable. So, a key non modifiable risk actually lies in your genes. For example, African Americans are at the highest risk of stroke in the US, and this ethnicity, as well as Hispanic Americans, are at about double the risk of CVAs when compared to Caucasians. Family history is also significant, as strokes in the past generation, along with genetic predisposition to other modifiable risk factors such as obesity, hypertension, and diabetes, can lead to added risk of CVAs. Now to modifiable risk factors, which lie in medical conditions and lifestyle choices. For example, hypertension directly increases risk of narrowing or clogging of the blood vessels due to high cholesterol, also known as low density lipoproteins, leading to either a lack of blood supply to the brain or aneurysms, which lead to strokes of the hemorrhagic variety. I have a hard time saying that word. According to a study by Sylvia Dye and others, 60% of strokes are due to arterial hypertension. Also, cigarette smoking reduces high density lipoprotein cholesterol, which is the good kind, increases triglycerides and blood viscosity, which leads to buildup of the plaque in the arteries. According to CDC, smokers are 3 times more likely to have strokes than non smokers. Also, sedentary lifestyle. The less active you are, the more likely symptoms like hypertension and obesity and diabetes, as other risk factors, can increase the chances of developing strokes. And exercising does the opposite of that. Before breaking down what CVAs do to the brain, let's talk about how the brain normally works. So, first we have the blood flow to the brain, which is supplied via the carotid arteries and the vertebral arteries, both main sources of blood, together forming the circle of Willis. Now to the regions of the brain. Let's start with the cerebrum, which is the largest part of the brain. It's responsible for our decision making, critical thinking, and a lot of our personalities. The cerebellum is more of our autonomous movements and balance, stuff we don't think about. And the brainstem, which governs our breathing, heart rate, and swallowing. All of these send information via neurons through neurotransmitters. And now, how do CVAs make our brains and our bodies go, me hoy noy, me noy? And this is just a graphic kind of touching on what I already explained about ischemic strokes versus hemorrhagic strokes. And how does this interruption of regular blood flow to our brains affect our bodies? Now, something important to know about strokes is if it happens on the right side of your body, it's going to affect the motor functions on your left side of the body, and vice versa. Now, when it comes to cognitive impairments, if it happens on the right side, it's going to affect your problem solving ability in a sense. So, spatial skills, concentration, stuff like that. And if it happens on the left side of your body, you're going to have more issues with speech and communication. So, reading, writing, and actually speaking. The functions that are limited often depend on the location of the stroke, with the exception being ambulation. Either way, that's going to be compromised if it's a serious enough stroke. And this can be addressed through gait training exercises as well as strengthening of bilateral lower extremities. And you have driving, which is a little bit more of a spatial skill, requiring you to position yourself in front of other cars or even people with precision. And this is a right sided demand that can be worked on with toe tapping exercises, target practice, kind of like pointing a finger at exact locations. And you can also do D1, D2 range of motion exercises to increase range of motion for steering. Now you have games, even ones of low demand like mini golf that require balance and precision. You can address that through Sharpen-Romberg tests on low density surfaces, as well as reaching exercises to help with that function. Now, communication, as previously mentioned, is a left-sided activity, and teaching tactile cues and using speech language pathologists to improve articulation are better options for better communication. Now to the initial examination, which was conducted by the DPT at our facility. Hey folks, sorry, this is the only place I could squeeze in for this slide. It's kind of a busy one. But anyways, this is a series of tests that was conducted on my patient in the initial eval. First, you have gait demonstration, which in my patient's case, they displayed a slow cadence, decreased step length and height in the notes. They used an assistive device, which was a small base quad cane at the time of the initial eval, into my outpatient location. Now we have manual muscle tests. And in my patient's case, they scored 4s across the board for all shoulder movements in the left side, the affected side, and normal scores on the right side. For hip motions, patient scored a 4- in extension, adduction, and abduction with a 4+ in hip flexion on the left side. And patient scored normal right flexion and 4+ in the other 3 movements. And knee movements, patient scored 4+ in the left side and normal on the right side. With plantar dorsiflexion, patient displayed a 4+ on the left side and 5s on the right side, which is normal. Next was the Romberg test, which tests balance. Patient scored a negative with both eyes open and shut with a regular Romberg, which is just the feet kind of shoulder length apart. However, the patient displayed a positive test with a sharpened Romberg, with one foot in front of the other, with both eyes open and shut. So, prognosis. First, the short-term goals. Week 1, just wanted to get the patient educated and acclimated into the home exercise program that they were expected to commit to, which was basically just to maintain the results that were created during physical therapy. By week 4, we wanted to see an increase of strength by a half grade on the manual muscle test in both the upper and lower extremity of the left side. Also, by week 4, we wanted the patient to pass the sharpened Romberg test with their eyes closed, which they initially failed in the eval. Now to long-term goals. By 2 months in, we wanted to see the patient improve their left-sided strength on both the upper extremity and lower extremity by having normal manual muscle test scores on each. Also, we wanted to see an increase in balance by improving their single leg balance with their eyes closed to 10 seconds. So now I'll be describing typical physical therapy interventions for CVA patients, starting with the acute phase, which is basically to maintain and eventually restore ROM and mobility. So stroke patients are initially very low functioning in their movements, very rigid, lacking range of motion, and these movement patterns, D1, D2, help restore that over time, first doing it passively, but then they assist and eventually do it on their own. We are also trying to restore their gait mechanics and ambulation gradually, so starting them sitting and doing these stepping motions while seated can help restore that. Another thing compromised during strokes are balance. So eyes closed, that creates more of a challenge. So standing with your eyes closed eventually with a low density surface increases the challenge of balance and helps restore that over time. So next we have subacute interventions, which is essentially just a progression off the acute and further strengthening interventions. So first we have mini squats with a Swiss ball against the wall, with the ball providing a little bit more of a smooth motion, but still progression from sit to stands. Next we have seated rows, which implement bilateral strength and introduce intermediate coordination skills as well. Last but not least, we have straight leg raises that are weighted, which increase hip flexion strength, which directly helps with gait function. Finally, we have chronic phase interventions, which is essentially what my clinical rotation deals with. And this is all about promoting function with strength mixed with balance. Now, this is essentially the Sharp and Romberg test, and this was something that my patient couldn't achieve through subacute. So this is a good indicator of balance worthy of outpatient activity. The next two interventions I'll be describing are ones that I directly implemented onto my stroke patient, as well as other high functioning patients with lower extremity deficits we were trying to improve upon at the clinic. So here we have standing hip abductors, which improve glute strength through abduction, which directly help with gait stability as well as mobility. So we have the foam surface, which provides elevation, forcing them to stand on one leg, and also challenging balance on the plantar lower extremity through a lower density than what the ground would provide, while demanding a contralateral glute contraction through the TheraBand. So my patient, before I even met him, he progressed from weight-free abduction, then to TheraBands, which gradually increased in resistance over time, and eventually began using foam mats to not only provide a platform to stay balanced on one leg, but also challenge ankle stability as well as strength with lower density than the ground. He used a high density foam mat while I was dealing with him. He hadn't yet graduated to low density as that was still too challenging for him. Next, we have a Bulgarian squat lift, which I love this workout because there's so many endless progressive variations you can add to this. Starting first, just weight free, just getting yourself to propel yourself off the ground with one leg, and then implementing weights first just as added resistance for the lift. And eventually you can upgrade that to bicep curls, either one at a time or both. And this helps restore coordination as well as strength, as well as balance through only using one leg. So this is perfect for high functioning stroke patients, in my opinion. And my patient in this case was able to complete a Bulgarian squat lift with 5-pound dumbbells into a bicep curl with each hand. The only issue was the patient was still showing quite the deficit compared to the right side on the left side as far as the lift of the bicep curl. However, as far as lower extremity, was about even. If I was presented with a similar patient case, I feel like I would head into it with a better understanding of knowing when to be conservative and when to be motivational. What I mean by that is, like with a lot of patients, you kind of got to keep cueing them to keep going. They bring that energy like they're there because they feel like they have to be there, or they literally have to be there, and not because they want to be there. My patient was the exact opposite. He had that drive to improve day by day. He had that fire, which brings that fire out of me to be the best PTA I can be. He's the type of patient that makes me want to be a PTA, and also the reason why I picked him as my case. So what I mean by that is he would start to compensate Valsalva maneuver here and there, kind of like the barely able to lift an arm, like his left side specifically. And I would have to tell him, especially one time he was about to cramp. He was getting increased tightness in his glute. And I told him, hey, take the 10 seconds, 15 seconds to relax, let the muscle loosen back up instead of having it take a week or two to regress and just do stretches. You don't want to do that. You want to just moderate to a degree. All the services provided were perfect. I had a great CI that gave me just the right amount of autonomy, who was also there if I needed help. I had all the equipment necessary, and I just had plenty to work with to bring these patients to optimal results. there was also more than enough literature and research that I was able to dig into to find interventions to help with stroke cases of all phases. Google Scholar took me to plenty of resources, so I was definitely able to do what I had to do to find what I had to find whenever that was needed.